Hello, today we're going to cover how to log in to the platform External Review as a Service, or ERaaS, to view your case sheets. Each month you will get an email saying that charts are ready for review. It will have a link to this site. You want to bookmark that site and create a bookmark so that you'll be able to locate that in your toolbar. You will sign in with the username and password that was given to you. Once you log in for the first time, you'll want to go to your account settings and ensure that your name is correct, your phone number, your email address. Create a new password that has to have more than 8 characters and must include one number, one uppercase, one lowercase, and one special character. You can create your own security question so that if you forget your password, you'll be able to do that. Select your language and your time zone, and then update the settings. Otherwise, to go in and review your charts, you just hit Physician Review. And this person has, this is a test site, has 5 charts. You just hit the first link. You can see the background information about the chart. Notice that there is no account number or medical record number here. That information is available if someone wants to research the case in more detail. However, this is an educational process, so we're hoping that the physicians will take this as an opportunity to study their case management and earn CME credit. So in this case, we have an 80-year-old female patient hospitalized for 15.4 days, discharged alive. It's a medical case. These are the diagnoses taken from the discharge summary. This is a list of the past medical history as taken from the H&P. If we don't have the H&P or the discharge summary, then we put together as much information as we can. We can identify any potential complications such as prior recent hospitalization, extended length of stay, fall, adverse drug event, adverse transfusion reaction, etc. We can flag special problems relating to the review of this chart. In this case, there was a comment about whether or not there was an indication to get back-to-back RBC transfusions. So it said indication for back-to-back RBC transfusions is uncertain. Here we can see that in the upper right-hand corner, you can see that the patient received 2 units of red blood cells, no plasma, no platelets, no cryo. These 2 units were critiqued as deferred. There is a further discussion of how the critiques are performed. However, our loose definition of an avoidable transfusion is one where the physician in hindsight would probably say, gee, I guess I shouldn't have done that. So this isn't about a 7 or an 8 gram hemoglobin. These are about transfusions that I think most people would say were probably unnecessary. If it's marked as no critique or the blue category, that means that we didn't have the transfusion record at the start time of the transfusion, so we couldn't evaluate that. Remember, up to 70% of transfusions are perhaps not beneficial, so it's not surprising that we only classify 5 to 10% of transfusions as totally appropriate. That doesn't mean that others aren't appropriate. It just means these are so appropriate that if you're in a bloodless medicine or bloodless surgery program, they would strongly consider giving blood in that situation. And then about 50, 60, even 70% of the time, units, as in this case, are deferred, marked defer, which doesn't mean that they should have given the blood later. It means that we're not making a judgment one way or the other. And this is very important because it gives physicians a unique opportunity to study their case management in hindsight to say, gee, did I really need to give that unit of blood at that particular moment in time? Could I have done something else? Could I have waited? Could I have got another CVC? Could I have given IV iron? Or more importantly, if you're now faced with a similar situation in the future, will you consider changing the way that you've been practicing for perhaps 23 years based upon what you're learning by looking at these case sheets and earning CME credit. So the system will track how much time you spend in the system, and you can be awarded CME credit for that activity. So we convert peer review from a traditionally adversarial process into an educational process where everyone can learn. So we have the peach color, brown colored column here, the vital signs, which are color coded. So we can see blue is low, red is high, so you can fairly quickly spot when something's going on with a patient. We have our key laboratory tests here. Hemoglobin, MCV, platelet, INR, PTT. The test type indicates whether this is a CBC, which there would be nothing in here, an H&H, point-of-care test, arterial blood gas, etc. Other laboratory tests are listed as line items. We have a chronologic list of all the events between admission and discharge. So this is an encounter history that was entered in 9 days, 8 hours, and 11 minutes prior to admission. This hematocrit was performed 7 days, 1 hour, and 45 minutes prior to admission. The clock is set at 0 for admission. We have various medications, the H&P, the discharge summary, the anesthesia data, the operative report, consultations, ECGs, CT scans if relevant. So we have all the pertinent information that we need in chronologic order to help identify and evaluate, or to evaluate the patient care. So I already mentioned that 2 units were critiqued as deferred. So you can scroll down here. Here's some iron studies that were performed 9 hours and 9.5 hours post-admission. The patient has an MCV of 95, hemoglobin's 7.2, iron saturation somewhat low at 16%, ferritin 484, iron 34. They started ferrous gluconate IV, and scroll down here, and so we have a hemoglobin of 6.8 that was collected 19 hours and 22 minutes post-admission. Patient was given 1 unit of blood, red blood cells. There's some comments about the unit of blood here. More ferric gluconate IV, a 2nd unit of blood with no interval laboratory testing, and then additional comments here. So each physician is able to go through their case management to study the case quickly. If you hit the home button, you can go to the top. If you hit the end button, you go down to the bottom, and you can see for a 15.4 day length of stay, we've captured 312 lines of events. There is an ability to filter various things. So if we want to click on just the medications, for instance, we can see all the various medications that this patient received during hospitalization. You could then add the transfusion values. You can add the narrative reports and perhaps take away the medications. So you can filter on any of these events, and that should help speed up the review process. At the end of the review, you can actually provide feedback by going up into the upper right-hand corner, clicking Provide Feedback. You'll be able to provide a comment or a question regarding a case. Maybe you don't understand something, so you could ask a question here, and the reviewer will get back to you by email. You can click whether or not this review was helpful, yes or no, and you can make some other suggestions here to improve the process. So in summary, we've given you an idea about how to log in, how to review your commentaries very quickly, and to provide feedback. If you have any questions, you will be able to reach us through contact information on the email that you'll be receiving every month. Thank you very much.